Good morning, everyone. I'm Susan Masnack. I'm a nurse scientist in the Seidman Cancer Center at University Hospitals and also an associate professor at the School of Nursing at Case Western Reserve University. Before we get started with introductions, just a few housekeeping notes. This webinar is being recorded and will be available to view from the UH Research and Education Institute website. Please mute your microphones throughout the presentation. If technical assistance is needed, please contact the R&E team, Nicole Bollinger or Abigail Zona, who are on the call today. And if you want to ask questions, you can type them in the Q&A area or in the chat. Questions can be seen by all attendees, and you have the options to submit them anonymously if you prefer. And now it's my pleasure to introduce today's speaker, Dr. Julia Blanchette. Dr. Blanchette is a nurse scientist, diabetes care and education specialist, and program director of diabetes research at University Hospitals Cleveland Medical Center. She is also an assistant professor of medicine at Case Western Reserve University School of Medicine. She received her BSN from the Francis Payne Bolton School of Nursing at Case Western Reserve University in 2014 and her PhD from Case Western Reserve in 2019. She completed a postdoctoral fellowship at the University of Utah College of Nursing in integrated diabetes management in 2021. Dr. Blanchette examines the impacts of financial, psychological, health literacy, and healthcare system navigation barriers on diabetes self-management behaviors and outcomes during emerging adulthood and throughout the lifespan. She is dedicated to intervention development through community-engaged research. She employs qualitative, mixed methods, and quantitative analyses with interdisciplinary clinicians and scientists. Dr. Blanchette is a diabetes technology expert and seeks to reduce healthcare disparities and increase technology utilization. She also explores barriers and solutions to facilitate the transition from pediatric to adult diabetes care. Dr. Blanchette is currently the principal investigator for the Type 1 Diabetes Financial Toolkit for Emerging Adults. This is referred to as the iHero study, and it is funded by the Leona and Harry Helmsley Charitable Trust. She is also a co-investigator on a cognitive behavioral sleep self-management intervention for young adults with type 1 diabetes. This study is funded by the National Institute of Diabetes and Digestive and Kidney Diseases. Please join me in welcoming Dr. Blanchette.
Thank you so much, Dr. Masnick. I really appreciate the introduction. We are going to get started here. I'm going to talk today about my community engaged research in type 1 diabetes. Here are my disclosures. So this presentation doesn't involve discussion of devices or medications. Also related to my disclosures, the only related disclosure I have is my research funding. My other disclosures are not related to what I am going to go over today. So the learning objectives for today are to define community-based participatory action research, which will here on be referred to as CBPR, to differentiate between CBPR and other levels of community engagement and health services research, and then to discuss the application of CBPR in type 1 diabetes research. So before we get into the work that I do, I want to tell you a little bit about myself. So I'm a nurse scientist, which means I'm a registered nurse by clinical training, and I have a research PhD. I also have expertise in diabetes care and education. I'm a certified diabetes care and education specialist, which is an interdisciplinary certification. And I turn to research as a form of advocacy for the greater type 1 diabetes community. This here is me. That was me when I was 7 years old, right before I was diagnosed with type 1 diabetes. And that has significantly impacted my career trajectory. When I was diagnosed with type 1 diabetes, my mom and my diabetes care and education specialist really empowered me to independently self-manage, and they taught me how to advocate for myself and my peers living with diabetes. What was also very impactful was I spent my summers at a diabetes camp where I connected with others living with type 1 diabetes from very different geographic and socioeconomic backgrounds than where I was growing up. And I gained self efficacy, became proud to live with diabetes, and really learned about the powerful impact of peer support on self management. And so these experiences inspired me to go into a career to help people with diabetes. So today I'm going to share with you a little bit about my work as a clinical diabetes scientist driven by self-management experiences, community voices, and clinical insight. And so I use kind of these three ways to identify research gaps that I research. And my broad purpose as a scientist is to address community identified barriers to diabetes self-management, starting in emerging adulthood, but also across life transitions. So applying my framework here to my work, I was able to identify a pretty significant gap in diabetes care. So from my personal experiences, I was a young adult doing my PhD. I was navigating the healthcare system on my own for the first time. I noticed a lot of gaps in the transition to adult care, but I also went to pick up my insulin one day. I was 22 and on my dad's insurance plan. And unbeknownst to me, his plan had switched to a high deductible plan the first of the year, and I couldn't pick up my insulin. And I thought, wow, I'm a registered nurse. I'm studying diabetes self-management barriers, and I don't even know how to access what I need. And so that was very eye-opening for me. And it really changed the research that I was doing. Around the same time in 2018, a man named Alec Rayshon Smith, he was 26. He just lost his insurance as he transitioned off of his parents' insurance. He actually passed away from not knowing how to access insulin during that time. He couldn't afford the out-of-pocket cost of his insulin, and he didn't know his other options. And so his mother, Nicole Smith Hull, is an incredible community advocate, and she really started to raise awareness about lack of emergency insulin access laws, but also about the very high costs of insulin. And that really started a movement within the type 1 diabetes community. And a lot of young adults in particular started to share their experiences about high diabetes medication and supply costs, barriers to getting what they needed, and this long-term anxiety about being unable to afford or access what they needed to manage diabetes. And then from my clinical experiences, one of my first jobs as a diabetes care and education specialist was at an was as an at was an inpatient diabetes educator at a community hospital. And in that role, I saw a lot of repeat hospitalizations for individuals that weren't able to access insulin. And so taking all of these experiences together, I was able to identify that there were some significant gaps in diabetes care. And so back in 2018, when I started to realize all of this, I went to the literature and found that there was very little in the literature about financial stress, insurance stress, and the impacts on diabetes self-management outcomes, even though it seemed to be a very obvious problem. And so from there, I discovered that emerging adults ages 18 to 30 are impacted by financial stress in particular as they're going through the stages of emerging adulthood where there's a lot of different instabilities that happen. There's job transitions, there's gaining general independence, financial stress in itself, and then when you're on your own for the first time living with a condition, it really can complicate financial stress and health insurance stressors for these individuals living with type 1 diabetes. And then I turned to community-based participatory research to address this gap. And so the reason I was initially drawn to community-based participatory research and why I continue to use it is that it dismantles the idea that the researcher is the expert, and it really centers the knowledge of the community. And this was very important to me as a scientist who's also a member of the community that I serve. And I do have to disclose that although I belong to the type 1 diabetes community, I am not the sole representative of the community. And sometimes I have to reflect on my own biases. But that's also why it's important to turn to the greater community's knowledge to really drive the research that will help the community. And so here's a basic overview of a community-based participatory research partnership. So the partnership is when there's equitable involvement from all parties involved. So that includes community members, organizational representatives, academic researchers, and it's through all stages of the research process. This type of partnership enables everyone to contribute their expertise with a shared responsibility and ownership, and enhances the understanding of a given phenomena. And so in this case, it's financial stress and insurance barriers to navigating the healthcare system. But the really amazing thing about these types of partnerships is that it really creates sustainable and relevant solutions to serve the communities that we are researching. And so here's the community-based participatory research conceptual model from Wallerstein. So you can see in the first domain on the very left, that contains external and internal context, so socioeconomic factors. The health issue of importance in this case is diabetes self-management, the capacity of the stakeholders, which in this case, stakeholders are very engaged and involved. Then you can see the second domain addresses the structural, so the shared resources and agreements and relational elements of the partnering process. And then these processes impact how intervention and research design are co-created with the community and produce intermediate outcomes like project sustainability, and then long outcomes like improving healthcare policies overall from the work together. And so the level of community engagement of a research project can exist on this spectrum here. And so for a project to be fully community-based participatory research, it does involve the community members to be part of all aspects of the study's development and conduct. And so this illustration here, you can see the differences in the levels of community engagement in research, and the minimal levels closely align with traditional research functions and emphasize sharing information back to communities, but the research is conducted kind of without the community insight. And then the most engaged stages have bi-directional relationships where there's equitable sharing between the researchers and the community members. And so when you're trying to figure out if your research is community-based or community-placed, which is like a lower level, or participatory higher level, kind of think through who's making the decisions. Are these shared decisions? Is there one side that's leading it a little bit more, like the academic side, kind of pushing the decisions more? Is this really a collaborative process? And then kind of think about how are both sides empowered, and then how are we disseminating the findings? And I actually had to think through this because you'll learn more about how I got to where I am, but I didn't necessarily realize that I was conducting fully engaged participatory research until it started happening. So we'll talk more about that. So I'm going to tell you a little bit about some of my preliminary work and how I got to the iHero project. So this paper was my dissertation paper. It's an example of traditional research. So I didn't engage the community when I did this research. However, the topic was heavily influenced by what I had observed as really important topics to the community. And so my dissertation explored the impact of financial stress and A1C on diabetes-related quality of life in a sample of 413 emerging adults with type 1 diabetes from across the United States, and it was cross-sectional, led by an academic team. We found that higher levels of financial stress significantly impact higher A1C levels and lower diabetes-related quality of life. We identified that on average, emerging adults had moderately high levels of financial stress. And, so this was a problem that I'd observed within the community. And the next steps were really to figure out what do we do about these high levels of financial stress? We have some evidence now that it does impact self-management outcomes, but what's the solution? So I went into my postdoc. My postdoc proposal was actually based on developing a financial specific intervention for this age group. But what I quickly learned from the community was that there's substantial gaps in understanding health insurance. And health insurance is a key driver behind the financial stress. I did end up verifying this with a community advisory board later on, which I'll get into in a bit. But as I kind of described previously, emerging adulthood is a period when a lot of life transitions occur. It's a period of instability, especially surrounding finances and health insurance for those living with chronic conditions. And the health insurance landscape in the United States is very confusing. There's a lot of potential for high out-of-pocket costs, risk for acute hospitalizations, and then there's really high churning. That's what we call turnover of health insurance in this population. And that's because the young adult age group is the most likely age group to change jobs more than once a year. And so that can cause some fear with deductibles, lack of insurance, and lack of access to insulin and supplies. So I went to the community to verify that all of this information that I had learned in the literature was really impacting the type 1 diabetes community and to really understand if it connected more to this financial stress problem. So I did a very short survey on social media asking just one broad question: what comes to mind when you hear the word insurance? I had 43 young adults with type 1 diabetes answer this, and I made a word cloud of their responses. And so, as you can see, expensive was the word that stuck out the most. And so this was also very telling to me. So this what I did here is actually an example of community informed research. So I went to the community to ask them for some feedback, but it's still not fully community-based participatory research. So then during my postdoc, I ended up with the goal to develop and pilot a financial and health insurance education toolkit for emerging adults with type 1 diabetes. My specific aims were to develop a community advisory board to guide the development of the toolkit, to examine the feasibility and acceptability of the toolkit, and then to explore its preliminary efficacy on financial, psychosocial, and transition readiness outcomes. The intervention that we developed with the community advisory board ended up being a 10-part micro-series led by emerging adult peers with type 1 themselves. They kind of self-taped the videos, and then we put them together with nicer graphics, as you can see pictured here in this like intro scene. They were all online, and so what we did for this was we ended up pilot testing this toolkit here in a small randomized control trial. So there were 42 participants over 3 months. We collected data at baseline, 4 weeks, which was the post-intervention period, and then 12 weeks, and we completed 11 exit interviews that were optional, so it's about half of the intervention group. And those in the intervention group received access to this toolkit on Qualtrics for 1 month period, and they were able to view it asynchronously. And then the control group received the 3 most common digital health insurance resources for type 1 diabetes. And they also viewed theirs in a separate Qualtrics platform, so we could see if they were reading the resources in the control group. That was the best thing we could think of for usual care. So here's the feasibility and acceptability. So the intervention was feasible and acceptable. 90% of the participants started the intervention, and of those that started the intervention and that were in the control group, 100% in both groups completed. And then everyone in the exit interviews reported gaining financial and health insurance knowledge. There was high satisfaction. So most reported taking steps towards their finances and insurance after watching the toolkit, and some steps to advocate for themselves. However, some of the gaps identified for improvement were that many wanted extended access to continue using the toolkit, to actually use it to help through some of the barriers they were experiencing. They didn't want just limited access. And they wanted some more hands-on materials. So not just videos, but maybe some worksheets or something that they could kind of do problem solving for. So they all wanted more access though to it, which was really important. And then for the preliminary results here, so this was pretty underpowered, but what we found was that over time, the primary outcomes, so we looked at financial stress, psychological stress, and then transition readiness. They improved over time for both study groups. So you have to keep in mind that the control group did receive common online written resources, and they were compensated. So basically the next steps from here were to revise the toolkit to be more interactive, to create a larger scale toolkit that would be sustainable. So like this toolkit here was developed by an academic team. We had young adults take videos of themselves on their iPhones. And so it wasn't the I don't want to say it was unprofessional, but it you could tell that young adults made it. And we wanted to make sure that it was sustainable. So, keeping it on an academic um, or university server is not really sustainable for a toolkit that we want to disseminate to the community. And then we needed to test it larger scale and longer term with a no treatment control group. So we'll talk a little bit more about that. Okay, so now I'm going to get into our community partnership. So the Diabetes Link is our community partner, and they are the only diabetes organization for young adults that is, created by young adults. They incorporate real world lived experiences with diabetes, everything they do. And their mission is to empower young adults with diabetes by providing access to peer support, connections, and expert resources to thrive. And they have these three different main areas. They have their peer support, education, and leadership development. And where they really come into this project was with the peer support and education pieces. They also do a community needs assessment every year. And so the one they did during COVID, which was when I was doing my postdoc, they really found some gaps. And so during COVID, a lot of their programming initially was on college campuses. And so now they had to kind of think, okay, how do we make everything a little more online and engaging and accessible? And so what they found through their community needs assessment was that they needed some online place, like a resource hub or social media channels to really house all of their education materials. And some of the topics that they identified, this wasn't all of the topics, this was just the ones that related to our collective efforts, were health insurance, healthcare system navigation, and diabetes finances. So they ended up developing this resource hub. You can find it right now if you look online. You won't be able to find what we're working on, but you can find the resource hub. It's the Diabetes Links educational platform. They have resources that range from peer blogs to videos, infographics, and guides. And then every single piece of content on their resource hub is developed in collaboration with young adults with diabetes. And it's clinically or content, if it's not clinical content, validated by experts in the field. And it's free, accessible, and they want the larger population to be able to access it. And so during my postdoc, the Diabetes Link, what they called a beta launch of this Health Insurance 101 series for emerging adults with diabetes. And it was really the test case for their young adult resource hub. And so what they found was that this test case had a higher reach than expected. It had over 28,000 impressions and shares across social media and views of the video. So it was well received. And so, while the Diabetes Link was working on their resource hub and then launching this Health Insurance 101 series, I had worked on developing this health insurance and financial toolkit with a diabetes community advisory board. So I had actually been building a relationship with the Diabetes Link for a while. So even before COVID, I had volunteered with their organization as a next gen fellow mentor. That's part of their leadership and development area. And then I had also given some lectures about career development and about advocacy with some of their leadership development series meetings. And then I engaged their staff at conferences. I even co-presented at a few national conferences about young adulthood with some of their staff. And so we had really built that relationship. And then in 2021, we realized that I was working on this toolkit and testing it, and they had some shared interests. And so we started talking about how we could collaborate. And so in 2021, we wrote a grant together. And we planned a project together, and now we are conducting a 4-year multi-phase project together, and it is community-based participatory research. So I'm going to describe that next. So we are very grateful to have received 3-year pending year 4 funding from the Leona M. and Harry B. Helmsley Charitable Trust. So university hospitals partnered with the Diabetes Link to test and ultimately disseminate a financial and health insurance literacy toolkit for emerging adults ages 18 to 30 with type 1 diabetes nationwide. And so this is fully community-based participatory action research We wrote the grant together. We developed all the concepts together. We have co-investigators from the diabetes link. And then we've had either the diabetes link and or other community members involved through all phases of the project. The only thing they're not involved with is direct data collection, but they did approve what we were collecting beforehand, before we even submitted to the IRB, if that makes sense. And so then during the first phase of the project, we worked with the community advisory board to develop a toolkit, an enhanced toolkit is what we call it. And then the next aim, which is our present aim, is the randomized control trial. And we're enrolling emerging adults from across the United States to ensure we have individuals from Medicaid and non-expansion states. So of course, we're recruiting from university hospitals, but we also are recruiting from the community. And importantly, we're ensuring participation of those that are publicly insured, uninsured, and racially and ethnically diverse from both Medicaid expansion and non-expansion states. And that is critical for the clinical validation of this toolkit and its wide acceptability and utility. So just an overview of the 3 phases again. So we completed phase 1, which is to develop the toolkit. We're in phase 2 now, which is to test its efficacy. And then phase 3 is going to be all about launching the toolkit, community dissemination, and sustainability. So I'll tell you a little bit about how we developed the toolkit. So we used a qualitative approach. We had a community advisory board that had 10 members. We had 5 emerging adults who were either racially or ethnically diverse or were on Medicaid or previously uninsured, all living with type 1 diabetes. And then the other members were diabetes financial or insurance experts, and they aided with the design and content creation of the toolkit. We met 5 times for 60 minutes over the first year. And then we analyzed the transcripts with a thematic analysis, and we looked for the different content areas to include and also how to tailor the toolkit to racially and ethnically diverse individuals, and then those who are on public insurance or uninsured. This is just an overview of the individuals that were represented on the community advisory board. We had 100% retention rate, which was excellent over the year. And then here's just an overview of kind of the flow of what our meetings were. So we had a purpose for each meeting. We started with just some feedback about the previous resources that the link and that I developed. And then we got some more feedback about what needed to be changed, what needed to be added, how to really make it so that it would meet the needs of the population we were serving. And then we went back and forth for a lot of months on the content and on the topics. And the diabetes link took the lead with that, as they are experts in developing they really develop, they use this like adult young adult learning modules and theories. And so they took that as they also incorporated the community feedback to really develop engaging resources for this population. And then we had the community advisory board approve every single type of content that was created. And then finally, the community advisory board approved the whole toolkit. And we had to make some adjustments before we were able to launch it in the randomized control trial. So the content that the community advisory board recommended really is grouped into 4 different areas. So health insurance education, financial education, health system navigation, and then coping and problem solving. And the following themes emerged to tailor the toolkit, so to ensure that the content covered empowerment and advocacy throughout, including genuine stories and multimedia visuals for aesthetics, addressing clinician bias, acknowledging racial and ethnic disparities in care, incorporating cultural representation, and demystifying Medicaid stigma. And the real emphasis, so the most common theme, was to incorporate empowerment and self-advocacy throughout all of the content areas. So the iHero toolkit is on 13 different topics here. So each of the modules has at least 1 video and then up to 7 static assets. The static assets are like there are other digital resources. So there are checklists, like, what do I have to put in my backup plan, for example, or a script on how to speak to an insurance representative when you are trying to get a prior authorization through and you're not sure where it is in the process, or a worksheet about balancing your finances. And then there's also budgeting worksheets or comparing different plans. There's a ton of amazing resources in there, and they're very hands-on in addition to the videos that you can watch. And so this is what it looks like. I'm just going to play it for a few seconds here.
Definitely difficult to
Um,
manage the insurance world on top of the diabetes world.
okay,
Being
I think
diagnosed
it's
at
lagging a
18, I
little
was
bit.
thrown into both.
It's lagging, but you can see there's a young adult talking about her experiences. And then in addition to this video, here's some sample content that would be like connected to the video in that module. And then this is what it looks like for the participant. You can access it on a web browser or on any mobile device, and you kind of scroll through it like a website. And only the participants in the study, which I'll get into in a little bit here, that are in the intervention group can actually access this right now. So to end the phase 1 of this project, we published a manuscript on the process of developing the toolkit. It was very frustrating. It got rejected from quite a few journals because the feedback was that everyone wanted to see the randomized control trial results and the actual toolkit, but we knew the importance of sharing the process in hopes that it would inspire future collaborations with community members and organizations. And so eventually, we came across the Research Involvement and Engagement Journal, which ended up being a fit. It's an interdisciplinary health and social care journal that focuses on patient and wider involvement and engagement in research at all stages. So it is co-produced by stakeholders, including patients, academics, policymakers, and service users. And what's also really unique is that all submissions are peer-reviewed not only by academics, but also by patients. And there is a patient editor in chief, and there's also an academic editor in chief, and they welcomed methodology papers and encourage patient authorship. So we not only included members from the Diabetes Link on this manuscript, but we also have a couple of the Community Advisory Board members on this manuscript as well. And I don't want to get too deep into it because if you saw Dr. Ronas's presentation last month, she covered this, but one of the requirements of this journal is to use the GRIP2 checklist, and that checklist really helps ensure the project leaders are incorporating patient and community involvement through all steps of the research process. They also required this plain language English summary, which is amazing because it helps easily disseminate our findings and what we did back to the community members. So we're really proud of this. It's linked here if you want to read it. It's open access. And so now we're in phase 2 of the study. So phase 2 is the randomized control trial. So we are now evaluating the efficacy of the toolkit on health insurance literacy, financial stress, and diabetes self-management outcomes among emerging adults. And then again, we're ensuring at least 50% of the sample is on Medicaid or uninsured, and at least 50% is racially or ethnically diverse. So we're using a longitudinal waitlist control randomized control trial method. So the intervention group receives the toolkit over a 30-day viewing period through a secure link that the Diabetes Link Resource Hub website, Path Factory, initiates. And then the control group is observation only, that from previous experiences is probably the best comparator care for this type of resource that we're studying. And the intervention is completed in an asynchronous format remotely from mobile devices or computers. We are collecting baseline data. We're using REDCap to collect all of the surveys, and then there's a home A1C collection kit. Then at 1 month, we're doing, that's the post-intervention period. We're also administering the REDCap surveys, no A1C here. And then there's an optional exit interview for those in the intervention group. And then we're collecting the REDCap surveys and the A1C collection at 6 and 12 months as well. And then at 12 months, those in the control group will get access to the toolkit. And here's our randomization schema. I'm just keeping this up here so that everyone can see that we are ensuring equitable randomization in our control and intervention groups here. And so our recruitment methods have changed quite a bit over time. And so initially, we thought we would partner with, we were already partnering with the Diabetes Link to recruit through word of mouth and through their social media community. We knew that the Diabetes Link would likely recruit a very educated, white, non-Hispanic, privately insured population, which held true. Um, but we also had partnerships with clinical sites that had a lot of success in the past, engaging in research with racially and ethnically diverse young adults on Medicaid with type 1 diabetes. And so those sites have been incredible partners at what we're learning. And all of the sites kind of told us this going in, that we wouldn't be able to recruit in just a few months through their clinic-based recruitment methods. So we initially thought we'd be able to get 40 participants from each site, and now we kind of lowered the bar to not the bar, but we lowered the what we're trying to recruit through them to more like 10 to 15, because that seems more realistic. And we are partnering with some of the Diabetes Links partners to really push word of mouth recruitment to the racially and ethnically diverse populations. And I'll get into that on the next slide here. But I did want to show you, so we only have about a third of the sample left to recruit. And as you can see, we're doing really well, obviously with the privately insured and white population. We're doing decent with the racial and ethnic diversity inclusion. We really have a lot to catch up on with the publicly insured. So that's what we're going to focus our efforts on for the rest of the recruitment period. And so the Diabetes Link had submitted materials to our IRB, so that, and even like a whole plan with their social media, like exactly what they were posting, when, how often. And so our IRB had approved that for them to share our resources. So that was awesome. But what we've now included is the Diabetes Link has these content creator influencers that are influencers in the racially and ethnically diverse and like lower resource Medicaid insured type 1 diabetes communities that are now sharing some of the recruitment materials as well. And they also have partnerships with other community organizations like Kyler Cares, Thrivable, Blue Circle Health, and Diabetes, who have access to those populations. And so we're kind of moving that way for the community recruitment, instead of just posting on the Diabetes Link social media, which was really drawing in the same population. And then for the clinic site recruitment methods, the clinical partners have reliant IRBs. So each of the methods are slightly different, but at the same time, in-person recruitment at clinic works the best. And then some portal messaging works too. Here at UH, we did MyChart recruitment, where we were actually able to target those that were on public insurance or racially or ethnically diverse in Epic to receive an IRB approved message about if they were interested in our study. So that worked as well. And here's our UH flyer. It's kind of boring, but it has a QR code on it that links to our REDCap screening survey here. So I just wanted to share it. But what's actually exciting are the posts that the Diabetes Link uses. They're really engaging, colorful, and they're just more exciting. And so that was really awesome that they were able to do that. And so I did want to describe a little bit about how we are recruiting through the community and how this is working. So participants are referred from either clinic, the community, which includes the online community, or recruited through university hospitals. All of the potential participants go to a REDCap screening form that they fill out. And then the UH study team contacts the participants if they're eligible on the screening form and sets up a visit. And so during the visit, they confirm eligibility, and then they set up another visit on Zoom for the enrollment. And then the enrollment visit, they're required to show a valid state ID so that we can identify, or we can confirm their identity. And then we do have remote consent approved, so we use that process. And then all of our data collection is being collected remotely, so on REDCap. And then we have these home A1C kits that are also being mailed to the participants. They tell us each time point we're sending them which address to send it to. And then we use, which I'll get into on the next slide, some Twilio reminders. So when a REDCap survey is delivered to the participant, they picked when they enrolled, they either wanted us to use SMS, so like one-way texting from REDCap, or they wanted us to email through REDCap. And so they either get texts or emails. And so we're able to use Twilio integration to deliver this one-way SMS links to REDCap. And so it's working really well. We can also push reminders through there. So like, have you completed your home A1C test kit and put it in the mail? Press 1 for yes, press 2 for no, press 3 for help. And if they press 3 for help or they press no, we then know to follow up with them. So it's really nice because we know this age loves texting, but we don't want to be texting with them 2 ways in a way that's not HIPAA compliant. And then I'll share a little bit about our phase 3, which we're obviously not there yet because we're not done with data collection, but it is the dissemination and long-term maintenance plan. The diabetes link is heavily leading this. And so basically they have this 5-step plan here to successfully launch the toolkit back to the community. So first, they really want to focus on equity outreach. That's kind of what we're doing now, to make sure that the rest of the participants that we're reaching are racially, ethnically diverse or on public insurance. But they also really focus on healthcare provider awareness. They're going to all of the conferences, and they have some demo stations set up, not of our current work, but of like the initial work they did on the resource hub to gain interest. And then once we're done collecting data, they plan to launch it live to do kind of like a let's see real world usage and get some more feedback. And then while they're doing that, we will be doing some additional focus group feedback to understand how different communities will utilize this toolkit as a resource, and then also how it'll be utilized in practice to help that transition from pediatric to adult care age group. And then we hope, you know, by 2027 to release this back to the community, so that the community has a resource to help them with what they need. And we hope that it's clinically validated in the sense that it will show some improvements in diabetes outcomes. And so here are some great resources for community-based participatory research and community engagement. So university, so USF and then PCORI have some amazing, like anything you want to know about CPBR or community-based research. And then we do have our CTSC at Case Western that has a lot of resources as well. And then the GRIP2 checklist, if you're conducting community research and you want to make sure that you have community involvement at all phases, is also very helpful. So these are all linked here. And I wanted to say thank you to every single person involved on the research team. It looks like a couple people, oops, got cut off, which was not supposed to happen. But as you can see, this is a large effort from many team members, and I'm just so grateful that everyone's so excited about it and engaged, and that we're working on something that hopefully will be really great for the community. And then I'd like to acknowledge our funder, and then my postdoc funder, which was the Certification Board for Diabetes Care and Education and the Association of Diabetes Care and Education Specialists that gave me my pilot funding, as well as the University of Utah College of Nursing that where I learned and I conducted my postdoc preliminary work, and then obviously the diabetes link. And I will take questions.
Thank you, Julia. Very inspirational work, tremendous story, and I really thank you for sharing your expertise. We do have a question in the Q&A, and I would encourage people to submit their questions through Q&A. This one, great talk, Julia. The final module in the toolkit focuses on managing the emotional side of navigating finances. What kind of strategies do you teach for that? Does the toolkit include any stress management exercises?
Thanks for the awesome question, Sam. It doesn't include the extent of stress management exercises that I wish it could and that you wish it could. But we do have some clinical diabetes psychologists that helped us develop the content. And so there are some mindfulness and some kind of like, there's like this whole process where you stop, identify the problem, think about the problem, and break it down. So there's that, plus there's some mindfulness, easy mindfulness resources and strategies that are in there, but it would be awesome to have something more comprehensive.
You know, I had a question about the second phase in terms of the efficacy, and I may have missed this, but are you measuring or getting reports on how much the participant accesses the material? I'm wondering about the dose of the intervention and how you capture that in this type of study.
That's a really good question. So that was actually a really good learning experience for us. So that was important for us to capture the dose of the intervention from the scientific standpoint. And so we had to work with the diabetes link to make sure that they were distributing it in a way that we could track that. And so we are able to track it. We had to get permission for the diabetes link to put in the email addresses of the participants that they're using for the study. So that was a whole thing that we had to get approved. We did that. And so the diabetes link's actually able to send us now like the linked information, like how long did they access it? How many videos did they watch? Did they rewatch anything? And so they then send us those reports, and it's like they have to like de-identify it. It's a whole process. And then our data manager is uploading it to REDCap and relinking with who it belongs to. So we will look at that at some point, but we haven't, because it's such a process to get it figured out. We haven't looked at it yet. So.
Thanks, Julia. Well, I don't have to type the question, so I'll just make it easy. So as I understand the toolkit, it's not individualized to the patient's needs. Is that correct?
Okay, that's a really good question.
Yeah.
So we're trying to make it generalizable, but the goal isn't that the participant has to, or the patient has to use every single part of the toolkit. So by making it generalizable, the goal is to include a lot, but to also include different content that may or may not be applicable to everyone's situation. So there's Medicaid modules. And so we'll be able to see when we when we're looking at the data from Path Factory from the diabetes link, were there particular people that didn't access the Medicaid modules? We would hope and expect that. We don't want them to watch the whole thing if Medicaid isn't relevant to them, right? And so so there's a lot in there. And then like real world usage, we would expect that they would just access the pieces that they need as they need them.
Thank you. And I'm just wondering this is a great toolkit with 13 different modules. Is there opportunity with AI being everywhere? Can you streamline it more to their needs? Let's say, for example, they are accessing module number 13 about emotional side. So you clearly know that that's an area where the participant is seeking more information. Is there opportunity to at least give them the opportunity to explore it further? Just again, going back on the individualization aspect, and I don't know much about AI, but my understanding is it can help. Any thoughts?
So I didn't want to take credit for this because this is not me that did this. The diabetes link actually has some AI so that like if you go to their resource hub now, if you watch certain videos, it'll then feed you other content that's related to what you're watching. And so that will be part of this. Yes. It's not part of what we're testing though, because they weren't able to integrate the way it's set up. They weren't able for some reason to integrate that piece into the toolkit. So we just are going to take a look basically to see what videos were accessed, how many were accessed, and then we can look at the differences and characteristics and demographics for some of those individuals. But they do have a way to tailor the content when someone's on the resource hub, and they do plan to use that for the public launch.
And while we're waiting for more questions, I will just ask you another question. It's so once the trial is completed, and so what's the strategy you're going to follow for dissemination? How are people going to know? Will it be prescribed? Will it be through clinics, or what's the like a broader population or community-based dissemination plan?
Yeah, so we have a few different methods. So one is we're going to partner. There's a couple community organizations that are focused on disseminating resources, and so I don't want to like name them on this recorded presentation because we're still kind of working out some of the logistics. But we'll be partnering with those organizations to see how it's utilized within their patient population. And then the Diabetes Link has been working on building specific partnerships with clinics, specifically those that serve, individuals that have greater insurance barriers. And so they have a whole strategic plan that I'm not able to share on here as well for who they're specifically planning on piloting it with. So there's a plan, I promise, but that's more the Diabetes Link, and I didn't want to share things on a recorded webinar yeah.
And I have a couple more questions too. I don't see any in the chat. We have a question from Jan Cluse. This was an amazing presentation. Congratulations on the comprehensive and community-based integration. Is there an opportunity for those using the toolkit to share with each other?
Yeah, that's another great question. That's part of the dissemination plan. So, apparently there's something called Discord, and I feel I used to think I was young and hip and good with technology and a millennial, but apparently I am aging. So there's something called Discord, and apparently the Diabetes Link has these channels in Discord where their peers interact with each other. So part of the dissemination plan is also to try to put some of it into some of the Discord channels to see how the peers are interacting with each other, but that's not part of the intervention itself that we're testing. It'll be part of kind of the real world usage and dissemination piece.
And Julia, I know a lot of more novice scientists might be on this call. I wondered if you could talk about the challenges of leading a team, a research team, with this type of research. What was challenging for you, if anything?
Yeah, that's a really good question. So obviously it took a lot to get to this place. And so I think the biggest challenge for me on the personal level is figuring out like where my strengths and weaknesses are in leading such a big group, right? And like learning how to really be a manager was something that I didn't, obviously you have to manage people if you're in science and you're leading science, but that's something that really come out over the past couple of years. But the other thing is it takes time and it takes effort. And I've had to, working up to this, I couldn't just work like 9 to 5. I really had to go out of my way outside of my work hours to build connections with this organization, build connections with the community. And I've put in a lot of time to helping the Diabetes Link organization with some of their projects for the community, and even with this project, helping them when their burden has been too high. That's what I've done as a co-investigator. So I've helped them with some of their tasks when they've needed it too. So it's been a process. It's been a learning process. It's been a lot of work, but it's been great. So
It seems that you've made great partners across the country and across the world. So that's fantastic. Um, if you had to give some advice to a nurse who may be thinking about getting their PhD in nursing, there's such a shortage of PhD prepared nurses in this country. What would you say? What would you say to them? What would you advise? I have to ask that question. You know that, Julia.
yeah. So Dr. Masnick and I talk about this a lot off of here. But I think one of the things is I really wanted to, I love providing diabetes care and education to my community, but I really wanted to also help solve clinical gaps and address some of the challenges. And so research is what I've gone to do that. And there's so much you can do with a PhD in nursing. I'm working at a hospital and a clinical nurse scientist role, and I am able to do this amazing community engaged research. So I think also know that like there's what you can do with it, and it's so rewarding. And it really, I'm really happy with what I've been able to do in my career, and I wouldn't be able to do this without a PhD. So
Yes, you have a very bright future ahead, congratulations on all your achievements. Sam, did you have a question?
Yeah, I just two questions. First is thanks for bringing up this point around we have very few new nurse scientists across the country and across the world, and as the director of the center, I must say we are very fortunate to have, of course, people like Julia and Suzanne part of it, but we are very happy to support the next generation and whatever it takes to facilitate that. So there's an open invitation for any aspiring nurse scientist. We have a fantastic health services research center with fantastic faculties like Julia and Suzanne. So we are very committed to strengthening the workforce. So that's just when I had the mic, I thought I should make use of it. So just my final question, Julian, so this is, of course, very US specific, and I understand we have a very unique health system, but it's a very helpful tool. Even with, I have worked in countries with socialized medicine and worked in low and middle income settings as well. And these aspects some of these aspects will be very, very useful. So have you thought about extending, or I don't know if it already exists in other parts of the world, but extending this, of course, diabetes is a major problem in many regions across the world. So can it be extended to other parts, or what would it entail to extend it to, especially to resource limited settings?
yeah, so I think there's certain things that can be extended to anyone with any type of diabetes, any chronic health condition, like the coping videos, right? Or the how do you navigate? Wow, I almost made a board. How do you advocate for yourself? And so I think there's parts of it that could totally apply no matter like what the setting is or what the country is, but because emerging adulthood itself is really, it's kind of specific to North America because of our cultural influences. And so if you think about the way that some of health insurance and financial videos are developed, it's really grounded in our culture. And so I think there's some that definitely could be used in any setting, but others that are going to be a lot more relevant here in the US or maybe some other places in North America. So
Okay, with that, I don't see any additional questions, but I just want to say thank you, Julia, for taking time to share with us your work. I look forward to hearing about phase 2 and phase 3 results. So good luck to you, and thank you again. Thank you all for attending this webinar. Have a good day, everyone.
thank you so much. Thanks for having me.
Bye.